Who's into that guy? Hey, I hadn't been doing the reviews for the previous lecture. Did that help anybody? Not really. Thank you for your honesty. I appreciate it. Yeah, I mean, some of it's redundant, but if you're going through your slides the night of or the day after, it's probably helpful to kind of tally in. Well, I'm not going to try to convince you that it's helpful. For those that wanted it, from the first lecture, go back and look at Meniere's disease, patient presentation, etiology. Look at your seizure types, and I don't remember if these are in order, so you'll have to kind of roll with it. Specifically, your myoclonic seizures, tonic-clonic phase. Ooh, already? Find a deep breath. Oh. Alright. I walked in for like the last 5 mics. Yeah. Listen, in defense, like some classes aren't as fun. I don't know. I mean,
you missed the previous 145 mics.
Antimicrobial soap, I'll tell you that much. Alright, take a look at vestibular neuritis, patient presentation and treatment. Look up central versus peripheral vertigo. Remember we talked about that? I do remember that. It's coming back to me. BPPV treatment, presentation, status epi treatment, labyrinthine concussion. Look up absent seizure treatment. I think there's a question there about absent seizures and Zoran. And then, what did we do yesterday? Dementia and that delirium. You're like, we don't know, man. We weren't paying attention to it. Look up dementia risk factors, delirium features, memory types we talked about. Those are pretty easy to ask questions about. Exposing your patient head to toe, rapidic rash. If I give you a patient that comes in, and we'll talk more about this with meningitis a little bit later, but I put it on here for today. Alzheimer's disease presentation, pseudodementia, like what mimics dementia. We talked about every demented patient should be screened for depression. Alzheimer's pathophys, so plaques and tangles, we talked about those, and then FTD, the most common type. I owe you guys, I think I owe you guys an apology for yesterday for answering the phone. I thought that was kind of rude. Yeah. Well, either an apology or just some context. I don't know what I told. I can't even remember what I told you guys, but my mom's 74. She had a procedure on Thursday, and by yesterday was septic, and they took her back in yesterday morning. She doesn't care. She's not here. You'll never see it. Always abide by HIPAA. Always abide by HIPAA. But she had a colonic resection. You guys want to go more on some? You guys could have easily done another hour of FPA. I gotta tell you, this class, you guys have no poker face. Like, no poker face whatsoever. Like, I walked in 5 minutes into the class, and you guys turned around, and you're like, so I'm like, all right, I'm gonna close my eyes and pretend I'm asleep because I'm gonna start laughing. Oh man! And again, I really like it. I think he's a great dude. Great officer, love the guy. I think the course, that class, is just a little drier than some others. Not to say neuro is the most sexy and exciting thing. I think EMED and like maybe even just EMED would probably be a good one. But we'll make this fun. We'll make it happen. And you're like, next slide. Who said next slide? Who was it? Come on. Was you? Yeah. You gotta have fun, man. You gotta laugh at this, you know? All right, what do we think about when we hear movement disorders? I'll open it up for you guys, just get you guys involved a little bit. So, movement disorders, Parkinson's disease, ataxia, good. You guys can say anything. It doesn't matter. Like, you know, oh, yeah, nice. All right. Nice. Yeah. Drugs, yeah. Meth. What do meth heads look like when they're tweaking out? Like scratching and ripping at their skin. I got bugs crawling on me, right? So drugs can affect movement as well. What else? Tardive dyskinesia, excellent. What sort of, like, and again, I guess from mapping brain or for anatomy and physiology from a ways ago, what part of the brain kind of involves movement? Or does you just say everything? What is it? Cerebellum? Frontal cortex? Someone's putting their head on the front of their head. Yeah, I just hear a bunch of mumbling. Basal ganglia, I heard that one too. Maybe. Right? So, a lot of parts of the brain are involved in movement. What about like brainstem, maybe? Like what type of movement is that involved in?
Breathing.
Breathing, right? So it's a loaded question. I'm talking about maybe like kinesiology or actually like walking and stuff, but I wasn't really specific. So you could have said, I don't know, anything. Like the whole entire brain, all the neurotransmitters harmoniously working together in synchronized fashion. But okay, so we'll go through movement disorder. I think some of these, aside from me standing up here trying to act out some of these movement disorders, I have some short videos. We'll get through those. And then am I it for today?
Yes, sir.
So I have 66 slides between you and freedom for today. All right, hold your questions. Let's get it. No, I'm just kidding. We'll go to standard. We don't worry about. I actually don't look at the clock, which is bad. The other day I was like, oh God, it's been 60 minutes. We need a break. But if I do start going long, y'all need to let me know. I think you'll do that. So.
For sure.
All right, TLOs, ELOs, same here. Really dealing with a lot of the pathology we're going to talk about today has to do with basal ganglia, some of the cerebellum, some of the parietal lobes, frontal lobes, and we'll talk a little bit about that. But really just kind of baptizing you guys with a little bit more neuroanatomy that we already talked about. So specifically basal ganglia and Parkinson's disease, which one of you guys mentioned earlier, and we will talk about that significantly. Now, before we even get into this, let me ask you guys another open-ended question. How prevalent do you think movement disorders are going to be on active duty folks? Yeah, not. Am I going to see somebody with Parkinson's disease? No, just like yesterday. Like, am I going to see a lot of folks with Alzheimer's disease? Probably not. However, if you practice outside medicine, which you're all hopefully going to do, outside medicine, outside the military, excuse me, but you're all going to have long, illustrious careers, you're going to see this stuff. And it's also on the pants, that's why we talk about it. Some of the stuff I have seen, right? So like essential tremors, like you may see that. That's more common. We'll spend some time on that. Restless leg syndrome, right? That's something you would probably see or hear about. Hopefully you're not seeing it because it's a nighttime symptom and you're not watching your patient. If you are, we got some other issues. But. All right, and then we're also going to be dealing with some of our feedback loops, specifically dopamine and GABA, which we talked about GABA yesterday as a inhibitor or excitatory. Who says inhibitor? Nice. You're all right. Who says I don't care? Nice. Good for you. In fact, nice. Well, dopamine plays a both excitatory and inhibitory role, but we'll learn that with its effect on GABA, it can increase inhibition, which too much inhibition can be a bad thing. So we need that balance. These are what we're going to talk about, so we'll go through these by the eaches. Tremor, by definition, a movement that's involuntary, rhythmic, oscillating, which we said oscillation is what? Back and forth, right? Oscillating fan, the old school ones. Of course, we can't have nice things. We got duct tape fan up here, but it probably oscillated at one time until someone Hulk smashed it. And then it can be described, your tremors, as resting, postural, or action tremors. Again, we'll get into this. Is just kind of giving you the classification as we move forward, and then we'll talk about each one individually. Hopefully, kind of watching it will make it make more sense. I think seeing it sometimes helps a little bit better. All right, what did I do? Still up there. It's not turning here. Stand by. I got a spinning wheel of death. Oh, it's so weird. I said spinning wheel of death, and then you guys wouldn't believe it if I told you. Totally random. Anybody Disneyland in California? Does anybody know the Ferris wheel that like moves on little axis points? And so my son calls it the spinning wheel of death, and he literally just texted me a picture of it and said, I'll never go on the spinning wheel of death again. And I just happened to say the same thing without seeing it, so maybe we're synchronized here. All right, what is going on? Let me see. I totally have lost all institutional control of this slide deck. Oh, Microsoft PowerPoint is not responding.
Oh. Yeah.
Oh yeah, it responded. What in the hell?
done 3 slides.
What am I saying, Helen? Yeah, I know. We're 3 slides into this. This is totally hijacking this process. Let's get out of here. Let's just start over. Let's just take 2. No, we're not going backwards. We're going forward. So let's go to neuro, y'all, deuce. Let's rock. That's so bizarre. It just gets to this one and quits. Huh.
Start on the slide.
Wow. It's never happened to me before. Get your heads out of the gutter. I'm not really sure what's going on. So let me try to bypass that. You guys, this is my first day here. I don't know if you knew this, but all right, where were we? First of all, I'm going to round of round of applause for this guy right here. Peter over there bails me out. Thank you, my friend. All right, so we were classifying our tremors, and then again, baptizing a little bit with essential tremor. We're going to talk about this more in depth a little bit later, but what it is a rhythmic oscillation movement characterized by its relationship to voluntary motor activity, enhanced by emotional stress, and relieved with medications and alcohol. So you're not going to hear many things in medicine that get better with alcohol. Small quantities of alcohol make essential tremors disappear. So how do you think you're going to snuff that out with your patient? Like, when I have a glass of wine at nighttime, I notice it gets better. Right? So we're not telling our patients, like, go get a 30 rack and get hammered all day. That's where we're not going with this one. So we also aren't keeping a bottle of booze in our lower drawer. We're like, I think I know this one, but I want to pour you a shot and see how it goes. Sir?
Is this also one of the ones that's treated with medical marijuana?
It can be. Mostly we're going to talk about treating it with a beta blocker. But, so, a lot of things we'll learn, like the world of medicine in the military, and then the world of medicine kind of outside. You see a lot of folks are using medical marijuana for a lot of things now, seizure disorder being one of them. I didn't mention it yesterday because we don't have the ability to prescribe that in the military system. But I shouldn't say that entirely. That's not true. That's a little misleading. But anyways, I want to get back to this because I'm already behind the eight ball here. So, all right, chorea is a Greek word derived from the Greek word dance. This is another involuntary. And again, we're going to watch. Hopefully, we're going to see a video of this. But if not, we'll just move forward. That won't be too bad. But this is difficulty maintaining muscular contraction for strength testing, right? So we're going to see this as your patient is. Usually I'll have my patients like, hey, grab my fingers and squeeze, right? I'll have them squeeze my fingers, and what you'll feel is this milkmaid grasp where they just keep squeezing and relaxing, squeezing and relaxing, squeezing and relaxing. So chorea in itself can be a manifestation of other disease pathology, but we'll want to be sure that like we can identify it first and then kind of hunt for what the cause is. So some of the causes, speaking of, it can be hereditary, Huntington's, Wilson's, we'll talk later, benign hereditary chorea. Sydenham's, you'll see that from group A beta hemolytic strep, usually in your kiddos, secondary to not treating it. Chorea gravidarum, what is that? Pregnancy, right? So like 50% of the things that happen in pregnancy, like what's the cure? This is back in iPad for my women's health days. It's like deliver the kid and usually like 50% of the time it goes away, right? Don't take my word for it, but you'll learn it next semester. Drug toxicity, and then strokes, right? Some of the strokes can cause this as well. Hemibolismus, exactly what it sounds, large amplitude movements on one side. Flinging or flaring movements, and this is usually one limb. Monobolismus, or it can be both upper and lower, which is parabolism. And you'll see this with stroke patients. Stroke patients, if I have a stroke on the right side involving movement, typically you'll see some left sort of hemibolismus movement. You can see that depending on how severe the stroke is. Exactly what I said, most often due to vascular disease, contralateral, the other side, right? So, and then we can treat it, so we can give dopamine depleting or blocking agents. And if it's really severe, we're going to be referring them to neuro or neurosurgery, and they can actually cut parts of the brain if they need to. So, out of our wheelhouse, I told you guys I'd keep this honest with family, from a family medicine practitioner standpoint. But if you're managing someone outside and meds aren't working, refer them. It's certainly interesting what they're doing, but I'm not cutting people's heads. So, athetosis, this is another kind of, again, this whole upfront part is kind of definitions, I think, right? So, talk about chorea, athetosis, Athetosis is another Greek word of restless, slow, sinuous, writhing, involuntary movements, flexion, extension, pronation, supination, and flexion of the hands. Right? When it's considered prolonged posture, it's considered dystonia. But unlike that milkmaid's grasp that's going on and on, this one is constantly moving, right? So they may have it in their hand, and their hand just kind of keeps moving, flexion, extension, in and out, and they can't stop it. Okay, stop moving your hand. Hold your hands out straight for your Romberg, right? Or pronated drift, and their hand is like continuously moving. It's like they can't stop doing it. So, and then if it's severe enough, you can see there at the bottom, when it's prolonged in nature, it becomes dystonia, which dystonia, you can see there has multiple characteristics as well, or characterizations. So you can get, by definition, sustained muscle contractions, frequently causing twisting, repetitive movements, or abdominal posture. It can be secondary to absence of sleep. It can be enhanced with voluntary activity. And you can have focal or generalized. So focal dystonia you may have experienced, right? Torticollis, anybody know what torticollis is? Like crick in your neck, right? So you kind of feel like Quasimodo. You got something pulled in your neck. You can't do patients like this. Like, oh, I don't know what's going on with my neck. I slept weird. Blepharospasm, what is that? Your eyelid twitches. Does that happen to anybody here? Lack of coffee, lack of sleep, too many PowerPoint slides. It's awful, right? Like it first started to be, I'm like, oh, rub this thing, get it out of here. And it's just like your eyelid twitches. Sometimes when you're stressing out, family members will look at you and be like, what are you winking at me for? Like, I'm not. And then writer's cramp, maybe less common because like writing's kind of that lost art, but typers, maybe you get it when you type too much, your hands kind of get cramped up and your muscle cramps and you're like, oh my gosh, right? That's your focal dystonia. Generalized dystonia, cerebral palsy, and then you get an acute dystonic reaction, which we'll characterize later. But cerebral palsy in itself, you can see that young man there most likely has CP. Anybody, family or personal lives affected by CP? You guys have seen patients with CP, you just probably don't know it. Seen them walking around. There's a couple, or there were a couple workers here in the building that used to have it. Did I ask them? No, I can just tell based on kind of like their movements that it's most likely CP. And then acute dystonic reactions are like really fun to treat, and I see those every once in a while in the ED. Someone will come in and like it looks like someone scared the crap out of them, and they're stuck that way. They're like, and you're like, what's going on? They're like, I don't know. They're just stuck like this. And you're like, oh, you got to keep acute dystonic reaction in your differential. So tardive dyskinesia. Somebody shout out to somebody over here. Mention that. Is that you? Nobody wants to take credit? Oh, that's you in the back? Nice. What do you got? Anything good? Oh, that's like a Weight Watchers meal or something. What are you watching your weight, man? No? What is it? Anything good? Care to share with the class? Yeah, no, I'm just kidding.
Bring it up to everybody?
Yeah, exactly. So tardive dyskinesia, involuntary movements of the face and tongue. Do you guys remember going over this in Farm at all?
Yes.
Yeah, so this one's pretty obvious to see. You guys will be walking around Walmart or Target for you fancy folks, and you'll see somebody like always moving their mouth, right? It's most likely in your elderly folks. Some of your medications can cause this, but they just can't stop moving their mouth. Now don't be confused, right? So some of our older folks, what else do they have in their mouth that they're constantly playing with? Dentures, right? So that's the mimicker of this. So they may just have dentures and they're just messing around with them. So don't all of a sudden be like, tardive dyskinesia, and they'll be like, no, you young whippersnapper, like, they're my dentures, my polydent's not working or something. But all right, one of the most notorious drugs for this one is Reglan or metoclopramide. So I actually like Reglan, but it's Reglan prolonged. You use it for like long times. So I use it as part of my headache cocktail in the ER. I find Toradol, Reglan, and Benadryl have a synergistic effect. And it'll put people to sleep real fast. So then they can stop complaining about their headache. If it's a brain bleed, now you're in big trouble, right? So like they stop complaining about their brain bleeding, then they're probably dead. And you're like, well, that's why you do your physical exam beforehand. You get a neuro exam. So, all right. Definition: myoclonus, sudden twitch. We actually talked about myoclonic seizures, but sudden rapid twitch-like muscle contractions can be spontaneous, and then it's classified to its distribution. Does anybody remember a type of myoclonic jerk we talked about? The sleep one, right? So physiologic myoclonus or nocturnal myoclonus. you're going to fall asleep, or you just fallen asleep, and you guys probably learned already about, stage 1, 2, 3, 4, REM sleep, but as you're cycling in, boom, you move really fast, and everybody around you's like, oh, you feel like, either you fell or something, or you can feel your whole body kind of snap to, and everybody's like, what's going on? Kind of, what is that noise? That's a plane. I thought it was raining. Oh, back. What is it?
No, I thought it was the car.
Am I completely losing my mind? Like, does anybody else hear the noise? Oh yeah, well what's it saying to you? Just kidding. All right, epileptic myoclonus was a type of seizure disorder we talked about yesterday. Those myoclonic jerks, there's reversible myoclonus, essential myoclonus. Do I really want you to memorize these? What do you guys think? Nah. I'll probably tell you in the review which one to focus on. And that's a lot, right? 1, 2, 3, 4, 5 types of myoclonic. Ugh. I think I told you guys, for everybody except for one person that said it was, yeah, that's you, man, that I wanted you to know about myoclonic seizures. So I think that's the question that comes up. All right, tics. Tics are brief, rapid, recurrent, purposeless movements. They can be motor or phonic, right? So motor, obviously, muscle groups. Phonic is verbal. It can also be kind of sounds by moving air out of the nose, mouth, and throat. So it necessarily doesn't have to be like, when you think tics, most people associate it with Tourette syndrome, right? Actually, most people think of it associated with cropalalia or Tourette syndrome, where you say like swear words or inappropriate words. That's not necessarily all that tics can manifest as. You could have people. I had a kid in high school that would always he had facial. Most of your tics are going to be facial, like 80%. And he would do this weird thing with his neck and just be like, I'm not making fun of him, that's just what he'd do. And he was just moving air. So he didn't actually just stand there like the young lady that's on YouTube all the time and say, wind it up, little wieners or something like that. I don't know. If you know what I'm talking about, we're not going to watch her videos. But brave individual documenting her entire pathology with Tourette syndrome and bringing it to the forefront. So I'm not making fun of her. I think she's great. I don't know her name though. I forget. What is she? She has a TV show, so she's, again, probably doing more for Tourette syndrome than maybe anybody that's ever had it. So anyways, so they can be simple or complex. Simple, one movement, complex, right? Involving repetitive sounds, words, multiple muscle groups. That's your Tourette syndrome, right? You can also have complex motor tics with jumping, sniffling, or headbanging, which get pretty violent. So. You can get, these are some of your simple examples: shoulder shrugging, eye blinking, head rolling, complex, jumping, touching. Obviously it takes more than one muscle. And then that cropalalia, that profanity, or echolalia, usually they come in tandem. So you get repetitive profanity. And the interesting part about Tourette's or tics is, so suppressing the tic for the patient is extremely stressful. Like, it's like, I don't know what it's like, but I can almost imagine it being like holding in a sneeze. Like, does anybody hold their sneezes in? I don't know what's wrong with you folks. Like, you gotta let those things rip, right? So they have this urge to have this outburst, and for them to try to suppress it, they can do that, but it makes it worse. So they almost act it out to make it more, like, to give them more relief. So anyways, I digress. All right, Parkinsonian tremor. Somebody mentioned Parkinson's disease. 4 to 6 hertz. What does that mean, DL? It's going to be question 1. How many hertz is a Parkinsonian tremor? 1 to 2, 2 to 3, 3 to 4. Now it's slow. It's small. So Parkinsonian tremors are really fine, slow movements, as opposed to like a higher hertz or level of energy, where you're kind of flailing around. So, all right, that's what I really want you to take away from that. This increases during stress, most conspicuous at rest, improves with activity. So Parkinson's folks, once they get going, they get into a little bit of a rhythm. So they're slow moving to rise and start walking, but once they start moving, they're okay until they have to turn, and then it becomes a problem. So, all right, cerebellar tremors. We talked about the cerebellar portion of the brain enough, I think, the other day, but this can be secondary from stroke, tumor disease, right? MS we talked about, can be congenital, alcohol, Neat part about the cerebellar portion of the brain. So we talked about the cerebral cortex affecting the contralateral. Remember, your cerebellum is going to be the ipsilateral, same side. So if you have a stroke on the right side of your brain, the PCA, it's going to be on the right side affected. So that's a little bit different than some of the other stuff. But we haven't gotten a stroke yet. Maybe we do that tomorrow or the next day. But what else do we want to say? How do we, I'll ask again for the millionth time, how do we test this out? How do we isolate the cerebellar portion of the brain in tandem, everybody at once? Nothing, right? So nobody says anything? Is it on there? I don't care, man. I want to hear y'all say it. Yeah. Yeah. Repetition is how adults learn. That's what I've been told. So, yeah. Feel the shin, finger to nose, walk your patient, dysdiadochokinesia, that sort of thing, right? So, trying to put that stuff in clinical context for you guys downstairs when you're moving, folks, so moving around. So, psychogenic tremor, it appears as any form of movement, usually sudden onset and remission, increased incidence with stress, changes in direction and or body type affected, and it's usually decreased with distraction. I know some of y'all, I told you guys my story about throwing the football at the young lady. Yeah, don't do that. Yeah, don't do it. So I distracted her, right? So I was using medicine to help calculate my differential diagnosis. I just want to see her hand, see if she can catch. So orthostatic tremors characterized by, again, rhythmic muscle contractions. They can be in the legs or trunk, most notable after standing. So it's a little different, and decreases when sitting. Okay. Tremors decrease after sitting and being lifted off the ground and or walking. So orthostatic tremors, you guys can see these usually happens at higher frequencies, but again, don't memorize the frequency, and you see this in like older folks. So how much more of these do we have? All right, we'll do this, and then we'll see if I can throw these movies up, and then we'll just keep moving. So physiological tremor, usually by anxiety, fatigue, metabolic disturbances, drugs, toxins, or alcohol, right? Can be secondary to physical activity or sleep deprivation. Could be a common finding in alcoholics, but it could also be toxothoracicosis or poisoning, right? So consider any type of tremor, new onset tremor. What did the patient just do? What did they come from? Like, were they in a military vehicle where the halon system didn't work and they were exposed to carbon monoxide? You guys just got to kind of be able to put that together. So things to consider: arsenic, mercury, lead, carbon monoxide, probably more frequent than the other ones. I don't know many people that are getting mercury or arsenic poisoning, but lead maybe. How do we see lead poisoning?
Paint.
Yeah, kids eating paint chips. Typically you don't see it hopefully you don't see it much anymore, but just keep it in your differential. And then treat it. Treat the underlying disorder, right? Like you're exposed to too much CO2, I'll put you on some O's, let you suck those for a while, hopefully you stop shaking like a trout out of water. But, if not, we'll learn that beta blockers can help with a lot of our tremors. And why do we think, what do beta blockers do? No, I'm not asking you to mechanism of action, like inotropic and chronotropic effect. Like, what do beta blockers actually do?
Well, there's selective outside.
Just slow you down. Just slow everything down, right? Has anybody been on a beta blocker here? Yeah. So I developed an arrhythmia at IPAP. It made me, yeah. I haven't told you guys this story? Shoot. Like, I couldn't pay attention in class, so I was like, I'm gonna go get on some Adderall. Like everybody, hey. So the wizard put me on Adderall, and then my heart started jumping out of his chest. And I was like, oh my God, I think I'm gonna die. I hate IPAP. I hate my life. Kind of like you guys right now. And I'm like, what do I do? So I went back and talked to the wizard. The wizard being the psych guy, right? He's like, I don't think it has anything to do with the amphetamines I put you on. Let's double your dose and see how you do. And I'm like, hey bro, like I'm just a student, but are you sure that's a good idea? And he's like, it's an excellent idea. Okay, so I'm gonna be a good patient, and I started taking that, and then I really thought I was gonna die. Ended up throwing myself in a trigeminy. Went to the ER, and they're like, "Yeah, did you do drugs?" I'm like, "Only the ones that I've been given." But they put me on a beta blocker. Long story longer, and they literally call them the beta blocker blues. I feel like you can't get out of your own way, and it's true. Like you can't get your heart rate up. So like any running. Like walking up a flight of stairs, you just feel like you're stuck like in quicksand all the time. So they work though. Wasn't worried about my heart anymore. I was more like, why does everything suck so much worse now? Like, but how's your heart? I'm like, barely alive. That's good. That's how we want you here at IPAP. All right. I don't know. My confidence interval on this working is low based off what happened earlier. Probably deleted them or clearly I'm incompetent. Can't use this thing today. But seeing them, if they're not making sense, just Google them. Do a quick Google search. Like, hey, I didn't really understand what he was saying about athetosis, and look at the video, and that makes more sense to me. And again, when you see them, or if you see them in clinic, just be able to try to either go back in your repository or again, try to figure out, like, I'm not really worried that you're like, oh, that's chorea versus athetosis. It's involuntary movement. I think we said that for all of them. And then trying to delineate them from each other just becomes a little bit tricky, but seeing them, I think, helps certainly. So, all right, we'll go through some of these. Again, essential tremor. This one you may see, so I'll probably ask you a question or two on it. Previously called benign essential tremor. Don't really care that it's called that. It's the most common movement disorder. You can underline that. Half are a gene mutation and half are idiopathic. So sometimes we just can't tell them what's going on. Don't memorize the genes. I don't necessarily think that's important. So. It's a rhythmic tremor, 6 to 10 hertz, that's present only when the affected muscle is exerting effort. So you can see there, cradle to grave, so anybody can get it. Worse with stress, fatigue, caffeine, and nicotine, right? So that sounds like our patient population, right? Like your typical infantry person. So usually improves with alcohol, like we said, and then usually you're going to see this, you can see there, you can do the math if you want to, but head, voice, tongue, face, jaw, it's usually in the upper, it's usually in the head, right? And then it can progress over time and get worse. So small quantities of alcohol, not a lot, like a glass of wine, so not a bottle of vodka. So don't, I would just maybe not tell your patients to, like, oh, no, if you drink some alcohol, this will get better, right? Instead, we can treat it with propranolol, which is a beta blocker, gabapentin, pregabalin, or Lyrica, or benzos, which is a little aggressive, but essentially that's going to work the same as alcohol. So, God bless you. If that's not getting any better, send them to neurosurge, right? They can do high-frequency thalamic stimulation or surgery. That ain't our wheelhouse. So, we can send them, if they fail medical management, refer them out. So what does this look like? How do I get my patient? They're coming to you and say, like, my hand won't stop shaking or my face won't stop quivering. But how do I activate this? Let's say you guys can see the picture of my mom up there. It's not my mom, that's me. Hold your hands out, right? So that's why we do those physical exams downstairs, right? So you'll see them exerting effort in their upper extremities, and you'll see their hands shake, right? And as they try to control it, it may get worse and worse, right? So these are the ones that I've seen come out there. They try to, like, hold their hands straight up and they start shaking almost this much, right? So they do really well with beta blockers, but again, the side effect profile of your beta blockers. So acute dystonia we mentioned, sudden onset of sustained muscle contraction. So these are the ones that I was talking about. I've seen this in the ER maybe 5 or less times, but super interesting. You see these secondary to some of your medications. Antipsychotic meds, Thorazine, Prolixin, don't memorize this list, Haldol, Zyprexa, Risperdal, these are all antipsychotic meds. So that's why we support that we look at their med list. Phenagrin's another one, Compazine, cocaine, LSD, TCAs, amitriptyline, lithium. So there's a wide variety of medications. Interesting enough, these patients usually come in, they're kind of like, what else would I want to consider with a patient? I'll ask a better question. If they're like this and they can't breathe. Say strep? Stroke? Yeah, stroke's a good one. What's another one that can, tetanus? Yeah, absolutely. And we were playing Read My Mind and you did it and I read your lips, yeah. So tetanus, we talked a little bit about last block, that optosis, orissus sardonicus, where they're back bending, right? So that's a little aggressive, but I would be like, man, this tetanus, definitely on the differential. Acute dystonic reaction, maybe a little higher, because I haven't seen a case of tetanus. Read about them, and then we're going to give this person, it's on the next slide, I think. The coolest thing is this, is usually my EMS folks, I've already done this, but you're giving them Benadryl, and they get way better. So 50 to 100 mgs of diphenhydramine, IV, and like, they feel like $1 million, and they're like, I have no idea what just happened, and you're like, yeah, it's an acute dystonic reaction from a medication, like, we got to figure out I don't have to figure it out. I just have to stop it from happening. Because if they're locked up like that, right, for too long, what kind of secondary things can eventually happen? Related to, like, I don't know, their airway compromise. If you're doing it long enough, you can start developing some lactic acidosis, and that's bad too. But eventually, you know, I just got to, when I get them, they're either on their way down or stopping because EMS or paramedics, you know, a shoot hot paramedic gave them something. They probably gave them diphenhydramine and baclofen. You're gonna have a harder time getting somebody to take PO medications if they're locked up like that. So you could do like methacarbamol IM if you need to as well. So. And you guys can see there, admit to the ICU if there's airway involvement. That should just make sense, right? So your ABCs, if their airway, if you're concerned about their breathing, protecting their airway, just admit them. RLS, so it's been around for a while. 4 core symptoms. You guys can circle the bottom there. Urge to move the legs with or without sensation. Worsening symptoms with rest. Improves with activity, and it's worse at night. So you guys, this is another one you might see or have. I don't know, man. Does everybody just like get the sudden urge to just like kick their legs out and like move them all the time? I don't know that it's actually. I can't diagnose you with RLS unless I see you in clinic, which I don't think I'm allowed to do. But it happens to me after like I'm super stressed, long day, haven't slept in a while. I feel like it's hard for me to get to sleep. It's like my body's like, nah, man, you're asking for it now. So. Causes, primary is genetic, secondary, you can see there's multiple. So medications, hypoglycemia, opioid withdrawal, pregnancy, anemia, ferritin deficiency, renal failure, or peripheral neuropathy. So primary, genetic, the rest you guys can see there. So easy question would be like, which of the following is not a secondary cause of RLS? And I'll throw genetic in there, and you guys are so smart to be like, that's a primary. Nailed it, right? Treatment, mild, improved sleep hygiene. How do I do that for a patient? Nobody? You guys didn't talk sleep hygiene or anything like that? Previous course? CBT? Yeah, so easy, even easier than that. Like, so don't eat before you go to bed. No blue light wave spectrum. No cell phones. No computers. Schedule some downtime. Right. Read before you go to bed. If you can't fall asleep in 20 minutes, get up. Don't try to sit there and make yourself crazy. No? Does that sound familiar? Think your patients are going to listen to you?
No.
Depends on how hard you flex on them, I guess, but probably not. So, but there's some easy things, education we can do. Moderate to severe dopamine agonists, right? You can do Mirapex and Requip are your 2 that are popular for RLS. And then if if it's really bad, gabapentin or analgesic medication. Analgesics is getting kind of crazy because you're really blunting pain receptors to put someone to sleep. So I think that's a little aggressive. But all right, we'll do this, and I'm going to take a break. I was going to push, but you guys are dying. You think so? Who needs a break? All right, deal. If you have to take a break, get up and take a break. If I catch you sleeping, I'm going to bring you up here and stand next to me. Is that fair? Challenge has been accepted. All right, and that goes for long blinks. Don't give me that bullshit like, oh, just 10-second blink. That happened to me like last class or 2 classes ago, and he got rip roaring mad, and I was like, dude, you were sleeping. It's fine. Like, calm down. Anyways. All right, we'll just keep moving then. So I'm just having a grand old time up here. So, all right, Tourette syndrome, or if you're super fancy, Gilles de la Tourette, right? You guys can, I don't have to call it that. Tourette syndrome, okay. This is autosomal dominant. Boys greater than girls. Chronic, usually lifelong. Multiple motor verbal tics. We kind of talked about. Was her name Brandon or Braden? I think. Anyways, I digress. Can be associated with OCD or obsessive compulsive disorder, attention deficit disorder. And you guys can see your symptoms are usually going to begin before 21 years of age, and then you'll see remissions and relapsing, right? So differential diagnosis, right? So you got to consider other type disorders, Wilson's disease, Finnegan's chorea, bobblehead syndrome. You think I made that one up? It's in there. What do you think bobblehead syndrome looks like? Everybody, come on, all at once. I do mass participation. That's on. Yeah, it's literally, it's super rare genetic disorder with repetitive movements or bobbing of the head. A little disappointed in this side of the class. You guys, nobody participated. You did? Okay, I take it back. right. So labs or imaging, right? So what are we getting labs and imaging for somebody with Tourette's? To rule out any other cause, essentially, right? So there's no like memorization of like, oh, I must get a CBC and a CMP. No, you want to make sure there's no other organic cause before you're like, oh, you just have Tourette's. Maybe they're on some sort of drugs or having an overdose. So treatment, education, counseling, neuroleptic medications, Haldol, right? So another one's ORAP. We're probably not going to be managing that, or maybe you will. If you will, write back to me and let me know how it goes. But clonidine's another hypertensive medication that slows things down. So you're going to kind of stifle those tics. You're not going to get rid of them. And then Botox. What is? Whew, that's a weird pivot shift. How does Botox have a play in Tourette's? Yeah, like if I have a motor tic, I'll paralyze that thing, right? So I'm going to put it down and stop moving temporarily, right? So we all know that botulism is just a temporary fix for that, right? Anybody super into Botox? Is that your jam? Is that what you want to do after this? Good for you, man. You make a lot of money. So, anyways. All right, Parkinsonism. So Parkinsonism is like, think of this as a, so Parkinsonism is a syndrome. We're not talking about the disease pathology yet, but it's very similar to it. So think of it as almost reversible Parkinson's disease. So it's a clinical syndrome with similar symptoms, right? It includes tremor, rigidity, bradykinesia, or slow movements, postural instability, and they could have some cognitive impairment. There's 4 different causes: neuroleptic drug exposure. So again, we're talking about drug reactions, CVD or stroke, MPTP. What is that? Anybody want to take a swing? Nice. We got the word down. So methylphenyl tetrahydropyridine. That's neat. Yeah. So it's in. Let me think. Let me really search my database here. Demerol. So it's a substrate of Demerol. So folks that are making Demerol in labs at home, which they shouldn't be doing, may be exposing this. So don't do street Demerol, which I don't know if you're going to do a street drug. Demerol would be a weird one to do anyways. Also, you could find this in, which I think is more prevalent and relatable, is pesticides and herbicides. So you'd have to, again, talk to your patient. Like, what were you doing? Oh, I was spraying in my backyard with Roundup, right? So, and then I sniffed it because I thought it sounded good. Like, that's not great. That's a bad idea. But we don't ask those questions. We don't get the answers. So, and then encephalitis lethargica or von Eckemose disease. Don't care that you know that. Encephalitis lethargica. What does that sound like to you guys? Brain sleepiness, brain lethargy. So it's usually from sleep deprivation. It's super rare though, so, but don't worry about it. All right, Parkinson's disease. We'll have some questions on this, so kind of perk up, pay attention. So definitely, we want to know the clinical definition: resting tremor, cogwheel rigidity, bradykinesia, and gait impairment. So by definition, that's Parkinson's disease. Historical notes. I'm just going to jump because I'm not testing you on history, but I think history is interesting. I think it's kind of cool to see how long it's been around and where we're going, right? So we don't repeat some of the issues. But pathophys, I'd say it's important to know this. So you can put a star there. So this is damage in the substantia nigra with cell loss of the basal ganglia. We talked basal ganglia in the beginning. Dopamine is going to exert an inhibitory effect on the release of GABA. Without dopamine, GABA outputs increase. So now we've got too much inhibition, right? That's that slow movement, bradykinesia. They kind of look like they're stuck in quicksand. So too much inhibition is impaired motor function. If you need it, there it is. TRAP, tremor, rigidity, akinesia, bradykinesia, or postural instability. I don't care how you guys remember those 4, but they'll definitely be a question. You may see this picture on your test. So bradykinesia are masked faces. So it's kind of like this blank stare that your patient has, right? Or lack of emotion stare. Like, I don't know why I feel like we're picking on this guy. I don't know him from anything, but they kind of have a lack of, like, really this blank, kind of like 1,000-yard stare. Anyways, what does the term bradykinesia mean? Slow movement, right? So slow movement. So when you ask a patient with Parkinson's disease to turn around, walk down and turn around, how do you think that's going to look? Yeah, you did it in the back, man. I'm going to steal your thunder there. So first of all, they're going to walk like this, right? Really slow. And they almost have this pill rolling where they're You see, I'm doing it, man. And then you say turn around, and they're like really slow. You're like, dude, hurry up, we're trying to get out of here. I know. But that was the highlight of my day, man. When it happened. So, all right, your Parkinson's gait, unstable. So what do you think these people do a lot? Fall, right? So they come in and see me in the ER on Saturday and Sunday with what? Brain bleeds, right? So now you have a massive hematoma, subdural hematoma, epidural hematoma, or hemorrhagic stroke or something. So that's really what I see these folks. I don't think I know I've never diagnosed Parkinson's disease. It's not my wheelhouse. But I've seen a ton of them. And the way I find it out is not asking the guy who's in the bed with a brain bleed, is I look at his medications, and I'm like, dang. Family history, I'll ask him, whoever's at bedside, does he have a history of dementia? Oh yeah, and Parkinson's disease. I'm like, all right, cool, man. Got it. So, gait shuffle just showed you. Late features, orthostatic instability. You get this freezing on-off phenomenon, which I'll talk to you about in a second. Dysphagia, difficulty swallowing. Does that pose a problem? It's usually how we're going to get them. They're usually going to succumb to this disease from aspiration pneumonia or some sort of respiratory issue. So, dementia, frontal lobe dysfunction, see yesterday. Dysautonomia, so MSA, multiple system atrophy, so systems start shutting down. And then that bottom one, skin greasiness, seborrhea, which you'll learn about in derm. What the heck is that? So they have autosomal dysregulation. Oftentimes they're the oil secreting glands, right? So you would have to be like house MD to be like, seborrheic dermatitis, you must have Parkinson's disease. Like that's a late finding in your older folks. And most of your older folks have skin pathology anyway, so don't hang your hat on that. But this on-off phenomenon, has anybody heard of this? You guys talk about it? Did you talk about it in pharm at all?
Did we talk about it in psych?
In psych? All right, hit me. What do you got? I'm 20 yards downfield.
It's where they're doing the movement, but then the second they try to do something intentional, it suddenly like goes away.
Yeah, not bad. So really what we're talking about is how effective the medication is. So they have periods where the medication is working well, right? And they're developing a tolerance to it. So early diagnosis of Parkinson's disease, I start them on medication, it's working great. So it's on, it's working. And then all of a sudden their symptoms come back like that. And then that window keeps shrinking. So they're on, they're off, they're on, they're off. And what do we do as clinicians? We keep either increasing the dose till we can't anymore or adding other medications. And really what we're doing, because this is degenerative, is trying to buy them time. So they may be totally normal in the morning and totally abnormal at lunch. Take their medication, they're normal again and abnormal. So you may see this kind of like up and down or on-off phenomenon. So PET scan. So you guys, this is good to know. I hope this was something you guys went over in radiology, if you guys remember that far back. But really what we do is we can tag a glucose molecule and look at the uptake in the brain, and we'll see decreased uptake in the basal ganglia. You guys aren't going to be reading these. You're probably not going to be ordering these, but just it's kind of neat. It's nuke medicine, I think, is good to know that it's out there. So, all right, treatment, dopamine replacement, anticholinergics, dopamine agonists. I'll tell you what I want you guys to know for my test specifically. There may be more to follow. I think I stopped, like levodopa carbidopa is the biggest one I see out there. Still, it's tried and true. There's a lot more newer, cooler medications, but to be honest with you, even though I'm teaching this to you guys, it's outside my preview. I don't prescribe these very often, so I would have to look it up or defer to neuro if I was really going to have somebody manage this. So. All right, no medical therapy reverses or cures it. So majority of patients show lessening response in 5 years of treatment. So again, that first 5-year window is great. Then they start developing on-off. Surgeries are an option. We are not going to be doing that. So they can start cutting things. Deep brain stimulation. Actually seen some pretty neat articles on deep brain stim earlier in treatment and actually showing better long-term outcomes. But again, that would just be incumbent on us to realize the disease pathology, which I want you guys to know how it presents, and then if we were going to do this, referring them to a neurosurgeon who's going to be cutting. Death, choking, pneumonia, aspiration pneumonia, and falls. So head trauma and pneumonia usually is what I see. So, and it may be a while. It may take 20 years or more. So we're getting better. We're getting longer survivability rates, but eventually we're all going to succumb to the Grim Reaper, so it's kind of sad. All right, everybody good so far? We're almost there. We're so close. Well, let me tell you guys another story. All right. It's just like a long, slow kicking machine, isn't it? Yeah. All right, Huntington's disease. This one is rare. And again, the history's there for you. I think that's powerful. Until the hapless sufferer is a quivering wreck of his former self. So there's some behavioral ones that are associated with this one. So that'll kind of, again, if I'm studying this, I'm like, how is it different from the other ones? So genetic mutation causes premature cell death, resulting in atrophy of the cerebral cortex and a caudate nucleus. So concentrations of GABA and acetylcholine in the basal ganglia are reduced, which increases level of dopamine. Okay, you guys can see there, it's usually pretty early too. Anybody know for 0 points, want to take a swing at somebody famous with Huntington's disease? This dude, Woody Guthrie, you're like, damn, we just went through 6 slides. He's not paying attention. So, the guy who came up with "This Land Is Your Land," that song, that's Woody Guthrie. Like, he passed it on to 2 of his 4 kids. I think that's one of the more popular cases. I can't think of anybody currently. You guys can Google search it and prove me wrong. But all right, let me see what I want to go over real quick. I hate going backwards, but early, so mental changes. So again, irritability, moodiness, antisocial behavior, moodiness, excuse me. So we haven't really talked about, so early dementia patients, you shouldn't really see that. We talked yesterday about ultimate status, make sure it's not delirium versus dementia. If you clear the deck on delirium, you're like, man, this 25-year-old seems like they're demented. I keep Huntington's in my differential. You can get that chorea, Huntington's chorea, which is that movement we talked about, usually that milkmaid grip, so they can get that contraction, relaxation, contraction, relaxation. May just seem like restlessness at first, progresses in severity, usually all limbs, and then this tongue protrusion test, they cannot stick their tongue out and hold it out for like 30 seconds. So, kind of a weird test, right? You guys will, I don't know, maybe you won't feel this way, but when you guys get to, did you talk to Bruce yet? You're like, I want you to do this for 2 minutes.
Tomorrow.
You're like, 3 minutes? And you're like, 3 minutes, and like 30 seconds later, you're like, all right, like, we got a ways to go. Like, I'm just gonna sit here and watch you, right? Same thing for this, like a tongue protrusion test. You're like, stick your tongue out. They're like, 30 seconds is a long time to do that. The person's like, what are you doing, right? So they will want to move their tongue back in. They can't keep it out. So. Mildly interesting, right? So it's thought back in history that it may have been related to the Salem witch trials. They thought that they might have had a couple of them might have had Huntington's disease. How do you cure that? Tie a rock around their foot, throw them in a pond, and if they float, I guess they're not a. I don't remember that. If they sink, they're not a witch. They're dead. And they're like, yeah, good. We fixed the problem. What do I? Don't do that to your patients. Like that's not good medicine, right? Oh boy. All right, imaging on Huntington's. So what do we see here? So normal. What does the other one look like to you guys? Atrophy, cerebral atrophy. Look at those. Those are deep sulci. That should. So if you told me that was a 90-year-old's head, I'd be like, cool, whatever. Less enthralled about that. 20 to 35-year-old, something ain't right? We should be able to appreciate that. So if I gave you like a question, it was like, hey, your 25-year-old comes in with moodiness and you're concerned about dementia, you get a CT and this is what the head looks like. I want you guys to consider Huntington's, okay? Consider Huntington's in that patient. All right, treatments, right? So haloperidol, again, we're just trying to slow this thing down. We're trying to slow the train down, but you can do Haldol, you can do Risperidine, you can do SSRIs and SNRIs for the depression. Benzos can help with the sleep and anxiety. Some other medications that I've never used before, but look at the side effect profile. Tetrabenazine, okay. Yeah, these are some heavy hitters, but yeah. So your side effect for a Huntington's med is you're giving them Parkinsonism. Like, boy, do I have a deal for you. All right. Prognosis, no cure. So dementia symptoms are progressive. Life expectancy 10 to 25 years. And death is usually secondary, again, to pneumonia or falls. So, and they have a higher rate of suicide. because of that anxiety, depression. So this is a rare one. I've never seen it. It's out there. It's in the literature. But again, take away from this young person, young patient that appears to be going down that demented route. We just want to keep it in our wheelhouse and our differential. Speaking of rare, stiff person syndrome, right? Didn't name it. It's not. But actually, the name is pretty easy. Also known as Tin Man Gait, right? Nice. I can get down with that. So characterized by progressive muscle rigidity, stiffness, painful spasms triggered by auditory, sensory, and emotional stimuli. That's kind of neat. We haven't really talked about one that presents like that. So usually begins with stiffness of the trunk and legs, and then spreads to the limbs. You can get this hyperlordotic lumbar curvature. So again, I haven't seen it out there, but just keep it in your differential. Diagnosis kind of pearls, rests on clinical bids, lactate, pyruvic, ammonia. Those are all kind of kiddo stuff that you want to make sure you're checking out, make sure everything's okay. So treatment, supportive, right? So pharmacotherapy for seizures if they got them, treat them, see seizures from yesterday. And then spasticity, we can help out with that as well. So Wilson's disease, y'all have this one? Copper deposits in the eyes, talk about this?
Oh,
Kaiser flageolet rings over there, yeah. Are they real? I haven't seen any. I've caught Wilson's disease on active duty once, and it was just through a clinical suspicion and sending him out for a liver biopsy, and he came back positive, and I was like, oh God, what do I do now? I didn't pay attention that far. All right, so Wilson's disease is another genetic one. So this is autosomal recessive, affects copper metabolism, right? So that's specifically copper binding protein, impairment in conjugation of copper. So you can't secrete copper, so you get buildups in the body. You know, mostly it's gonna happen in the liver. You're not gonna see that. The eye is where you would physically see the manifestation, but there'd have to be like a lot of copper to see that. So. Kidneys, cornea, CNS, that's why we're talking about it, central nervous system, copper deposits, that's probably not good. They're going to manifest with some sort of CNS pathology, right? Specifically, tremor, ataxia, dysarthria, dyskinesia, Parkinsonism, cognitive dysfunction, and disturbances of mood personality. So again, if we're thinking down the realm, young person comes in and we're like, man, Roger said to think about Huntington's. I would probably keep this on your differential as well. So. Yeah, physical exam. You guys can see that Kaiser Fleischer rings, which is probably something you may have mentioned in optometry. Maybe not, I don't know. But again, I haven't seen them in clinic, but the literature says they're there. So labs will show decreased ceruloplasm and serum copper. You'll get an increased 24-hour urine copper excretion, and that's the most sensitive screening test. So you guys can just, again, you as a primary care provider, you may do that. So I had ordered that for this young lady that I had, and then sent her out for a copper biopsy or a liver biopsy. I wasn't like, oh man, this sounds like Wilson's disease, right? I'm not Dr. House, I don't get to do that. And then I'm like, go straight to a biopsy. And they'll be like, no, denied. Like, that's not smart. So we did the 24-hour copper excretion. It was positive, and then they were, recommend sending her to GI so they can poke holes in her. So it's all good. And then treatment, chelate the copper, get it out. So you guys can send them out. We're not going to be doing that, but they can go and get that removed. So. Whoa, 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 whoa.